this is going to be about clinical outcome assessment in rare diseases, and of course with a focus then on item response models. But I didn't put any question about pharmacometrics in the to the participants because I didn't really have an expectation of that, and the talk isn't about pharmacometrics. But given that I am a pharmacometrician, I thought I'd actually just have a couple of introductory slides on what pharmacometrics is, because not everybody will be knowledgeable, I believe. So pharmacometrics was really born out of pharmacokinetics, where we follow the drug concentrations over time, and then we create models for those longitudinal data, and that can capture aspects like drug elimination, drug distribution, drug absorption. And with time, this was extended to also to biomarkers and to clinical outcomes. But in every case, the focus has really been about time series, the progression of diseases, the aspects of biomarker change over time, etc. So the models that we develop have that focus, and we typically develop models that have some biological insight that could be useful for describing those time courses. And because biology operates at the individual level, we typically build those models using mixed effects models. And because they're typically nonlinear, we use nonlinear mixed effects models. So if you're thinking of pharmacometrics, it's typically nonlinear mixed effects models describing pharmacokinetic or pharmacodynamic or disease progression data. And the use of these, some use is in routine clinical care, particularly when it comes to pharmacokinetics, but mostly they're used in drug development, and they're used for extrapolation from one phase to another, for example. And they're also used when decisions can be based on rather assumption-rich models, like trial design, dose individualization, and dose selection. So that's very short of what pharmacometrics comes from. And of course, pharmacometric models are statistical models that we apply to data, but they're very particular kinds. I'm going to talk about pharmacometric models maybe now and then. So back to the main topic of today's webinar, and that is clinical outcome assessments. And in neurodegenerative diseases, the maybe most known clinical outcome assessment is the ADAS-Cog for Alzheimer's disease patients. As you can see here, it's celebrating 50 years next year, and it has 40 years, and it's still being used. What you can see here is that it contains tasks for the patient to perform, and the clinical staff is assessing the patient in different aspects. And of course, this is the clinical outcome assessment are here to capture the ability of the patient to function, and also capture the symptomatic picture of the disease. So these are two types of clinical outcome assessments. We have also other types. We have patient-reported outcomes. This was a clinical reported outcome measure and a performance outcome measure. So combination of those two. There are also observer reported outcome measures, in particular when the patient can't provide their own view on the symptoms or functionality. So these are different outcome assessments, regardless of which type of measure it is. The most common way of doing it is to transform the outcomes to numerical results and then sum those up. And here you can see that the different component of ADAS-Cog is not just different types of measures, they also have different numerical natures. So we have those that are just pass or fail type of questions. And we have those that are rater assessed, which are ordered categoricals. And then we have those that are repeated binary questions like word-based. All these are then summed up and into a total score, and that is the standard way of using these. But of course, the seminar today is about item response models, which then offers an alternative to this. And the basic assumption in an item response model is that all the responses to all these assessments are caused by a single common factor. And in case of the ADAS-Cog, it would be the cognitive disability of the patient. So because this drives the probability of completing correctly or failing to complete correctly the different tasks, we can formulate mathematical relationships between this cognitive disability and the probability of failure. However, the cognitive disability is a hypothetical construct. There is no given scale for this disability. That's something that we need to actually invent or come up with. And how this can be done can be maybe understood in taking the analogy with the IQ test, which I will assume that all of you are somewhat familiar with, that measures, of course, it measures cognitive ability and not disability. And as it states here, the average IQ score in Europe is 100. Clearly, cognitive ability is just as hypothetical as cognitive disability. So the fact that it is 100 in Europe is actually just by definition. It's said that the IQ, the median IQ in the general population is 100. So that has been defined. And also, if you follow further down, you can see that the standard deviation in the population has been defined as being 50. So that's how we can say then that an individual with an IQ of 150 is a very rare and highly intelligent individual, at least somebody who has a very high IQ according to the test. What we also can see from this IQ test is that it's typically assessed using different types of geometric figures or words, etc. And clearly, those geometric figures and questions are not the main. They're not of interest in their own right. They're only a way of learning about the underlying cognitive ability. And these can be exchanged for some other figures instead, without losing any generalizability of the IQ test. So while it's 100 and 15 for mean and standard deviation of the IQ test. When it comes to disabilities, it's more common to use the mean of 0 and the standard deviation or variance of 1, so a standard normal curve instead. And then if we look at the cognitive disability here, we can see that 0 is in the center, and we then have deviations from the median in terms of standard deviations of the reference population. And the reference population for an item response model depends on how it was constructed. This is the result of a model that was developed based on 2 large American databases with data from Alzheimer's patients all the way from very mild to severe. So this is a representation of the entire scale of Alzheimer's patient assessments. So then we can see here those mathematical functions I talked about are illustrated here in these colorful lines. Those are called item characteristic curves because they really are a characteristic of a particular question. The item response theory was developed after the Second World War in order to help develop tests for universities or for entrance to universities and for the military and for a number of other reasons. And when it comes to tests, what you typically want to do is you want to have for the test population, you want to have some easy questions and some hard questions and some in the middle, so you can actually distinguish who is having a high ability and who is not. And for that, it's the same when it comes to clinical outcome assessments. We would want to have, for the patient population we're interested in, we want to have tests that can actually discriminate where they are. And in terms of these mathematical functions, that means that what we would like to see is that they're distributed with their inflection points across the interesting space. And what you can see here is that actually the inflection points here is more above 0 than below. And that's probably because the ADAS-Cog test was developed based on when the interest was more on the more severe patient population. And that's not unusual with clinical outcome assessments. And with time, when new therapies are being developed, the interest often shifts towards a more earlier times of the disease trajectory. And so new tests are being developed or existing tests are being modified to better capture those early points. So we can look at these curves, and if we look at the word recall, for example, we can see that the first curve here and the second and the third have somewhat different shapes, and that it becomes steeper and steeper. The first curve is actually being able to recall a word after hearing it just once, and then the next one twice, and the last one 3 times. So what we can see is that negative values here, that means that the patient is healthier. So even quite healthy patients can have difficulty remember a word after just hearing it once. And actually, if you're towards the upper end here, you're almost like a healthy person, and even healthy persons might have problems of recalling words if they just hear them once. Whereas if you hear them more times, it is only more more disabled patients that are failing to remember the words. We can see the construction here, and this is the task of drawing a cube. And what we can see is that there is a again, even healthy subjects might have difficulty drawing a cube, so it looks three-dimensional, although it's two-dimensional. So because this comes from test statistics originally, this is often called a guessing parameter, because if you have like a multiple choice test, of course, there is a chance of getting things right, even if you don't know the answer. But in terms of assessing disabilities, it's a unwanted effect if even healthy individuals appear disabled in the test, and these can be providing more noise than what you would like to desire. And we can see, of course, the number cancellation here has a quite high problem in that respect. So one of the main advantages of item response models are that they do take into account the relative information content of the different tasks in a way that the total score doesn't, because even if you have just an addition of a random score that has nothing to do with the disease, that of course contributes to the total score, but it wouldn't to a item response analysis. So I will return to talk a little bit more about item response models in major diseases, common diseases, because that's where it's been used a bit more. But now I will be shifting to the use in two rare disease projects that we have ongoing under the EJP RD grants. And one of them is an IRT analysis of the SARA in autosomal recessive cerebellar ataxias. So SARA is the scale for assessment and rating of ataxia. So that's the clinical outcome assessment. The autosomal recessive cerebellar ataxias, the ARCAs, are a progressive disease which initiates with loss of coordination and then also ambulation. And this is caused by cerebellar disabilities, and it's a genetically defined disease with more than 200 genetically unique origins of this disease has been found. So this scale has relatively few components. So we have gait, stance, sitting, and speech disturbance, plus some tests that are performed both on the left and right hand side. So finger chase, nose finger test, hand movements, and heel shin slide as 4 different tests. It's the most widely used assessment in ataxias, and it's relatively recently developed, 2004, and it's a clinical reported outcome or clinician reported outcome. All these different components add up to 40 maximally. So the total score scale is between 0 and 40, and 0 then is no ataxia, and 40 is the most severe ataxia that can be measured by this scale. So it's the most common measure, but it has been questions for its suitability, both from regulatory agencies and from other investigators based on studies of it. So modifications to optimize the SARA is being discussed. There is still relatively sparse evidence of how it should be modified, and the analysis so far has been based on the SARA total score. So what we wanted to do here is to evaluate the properties of the SARA score using item response theory to be able to provide some more information for taking decisions about this. So just to reiterate, if we make an item response model, what we do assume is that the ataxia severity is an underlying cause for the probability of scoring in these different component of the SARA. And so this ataxia severity is what we want to quantify. And we quantify that in the individual patient as a latent variable value. We set the reference population of this latent variable to the ARCA registry, that I will present the data source very soon. This one will then be the probability of scoring a particular, having a particular score is going to be then a function of this latent variable. And the model we're going to use is, because all of these are ordered categorical outcomes, all the 8 different variables that we're looking at. And we have then the scale characteristics parameters. We have item discrimination, which is the steepness. And as I pointed out with ADAS-Cog, the steeper, a more steep function is more discriminatory, and that's providing more information than a flat one or a more shallow one. The difficulty parameters are determining how difficult, as the name indicates, how difficult a particular task is, or what is required to score one step higher. And when it comes to the difficulty parameters, of course, it is good to have them distributed and covering for ordered categorical data a reasonably large range of responses, so that you can continue to track a particular aspect of the disease with increasing disease progression. So those are the item related parameters that are making up the ICCs, the item characteristic curves. We then have also the individual latent variable values that are being estimated for each individual at each time point, and they're also they're dependent on this scale that was defined based on the ARCA registry. And yes, this is just to show that if we decrease the discrimination, we're going to see a more shallow profile, less informative component of the scale. And if we change the difficulty parameters, we're going to move the whole these profiles to the left or to the right. The ARCA registry contains almost 1,000 patients, which of course in a rare disease is large. Most patients had only 1 or 2 visits, but some had more. Most had a genetically defined diagnosis, but there were also a large component that didn't, as you can see. And there are 150 different genetic subpopulations, most of them actually containing only a single individual. And just to point out the obvious, if you're going to do an item response model, you need to have the data at the individual task or individual item level. And that's what we have in this registry. So the questions we wanted to answer in this analysis was, do all the items share one common underlying latent variable as we assume in the model? And then what are the characteristics of the different items and their performance? And can we use one IRT model across the different ARCA subpopulations? So to start with the first one, do they all share one common underlying latent variable? We can look at correlations between data. We can also look at how the model with its assumption of being caused by jointly from the underlying disability. We can investigate the residuals between the observed data and the correlations, the observed data and the predictions. And then we can look at the correlations, whether the correlations for both of these are similar to what we expect based on the model. So these are diagnostic plots, and in pharmacometrics, we're very used to graphically diagnose on our models because we're putting a lot of assumptions into our models. We also need to diagnose that those assumptions are reasonable. And of course, some of those assumptions we can diagnose based on data, residuals, and simulations from the model's agreement with data and residuals. So I'm going to go into these different plots, but in order to actually have a little bit better view, I'm going to talk about them one by one. So the first aspect, do we see a high correlation between the different items and their scores? And what we actually do, that's the positive number here. We see positive correlations, and we actually see positive correlations across the board. So all these items do seem to be positively correlated, which is a good thing if we think that they are all caused by the same underlying disability. Once we've developed a model, we can see whether the model predicts reasonably the magnitude of that correlation. And we can see that it actually does mimic reasonably well those correlations. We don't expect exactly the same correlations between all the different items because it depends on the location of the difficulty parameters and the discrimination parameters, but a general trend of a positive correlation. And of course, if the model can mimic that, that's good as well. So that's what we can see here in the upper triangle. In the lower triangle, we can learn some other aspects about the nature of that correlation. So the data are represented by the small blue circles. There you can see where data are present or not. The continuous line is the median, and the dashed lines are the outer percentiles, the 5th and the 95th percentile. So all that represents the data. The shaded areas represents the model prediction of where that median line should be and where the outer percentiles should be. And it's a 95% confidence interval of that expectation. So what you can see here is that there is a reasonable agreement between the observed median and percentiles with that predicted by the data and by the model. So that's for the data, and this can then be followed up with how do the residuals perform. And here we can see that when we fit the model to the observed data, we can see in general negative residual values, and the same actually goes for the simulations. And why are these residuals negative? Typically, what we would like to see is residuals that have no patterns, so that they should have a correlation of 0 with most things. But in this case, what we're actually doing is that when we determine an individual's latent variable value, that's like an average across all these different items. And of course, if you take an average across something like 2 items, then of course that one residual is going to be positive and another negative. So overall, their correlations are expected to be negative. The more items you have, the smaller this effect is. But if you have a relatively small scale like the SARA scale, that effect can be visible in those negative correlations. So how do the SARA items perform? So for this, we can look at these item characteristic curves. What we would like to see is that they are distributed across the different disease severities. We would like to have them separated so that no difficulty parameter is close to 0, so that the curves are overlapping. And we can see that they seem to be separated quite well. They actually also have quite high discrimination parameters. It's a little bit difficult to see from these graphs, but they have higher discrimination parameters than most existing clinical outcome assessments in this area, like in Parkinson's and Alzheimer's, etc. So, but something that is a little bit more easy to follow is the information content of the different items. So this is the Fisher information, and this tells us something about how much information does the different items give to estimation of a particular a patient's latent variable value. So the estimation of their disability. And what we can see is that gait and stance is the most contributing component here. And we can see that the shaded area here is where most patients are. So we can see that it actually can capture well, even in the area where the patients are more healthy than the typical patients in the ARCA registry, which is a good thing if you want to capture early deterioration of the disease. Whereas setting, you can see, is the opposite. It's not at all informative for early disease, but it's quite good at the late. And that's a complementary component. But we can see that all of these items have quite a positive, or they all have a positive information value, and would contribute well to the overall estimation of the individual components. And this was also confirmed in other assessments of the different components by recalculating after ignoring some component. So third questions are, can we apply one IRT model to all the ARCA genetic subpopulations? And clearly, these models are quite complex. They contain sometimes more than 100 parameters, because we have parameters for each individual items. And of course, if you have many items and many levels per item, this becomes quite a lot. And if you only have data from a handful or a dozen patients, that's not going to be a particularly well-informed IRT model. And you can question the relevance of developing one at all. So in rare diseases, we would hope that we can actually base it on the main disease, and it would be applicable across subtypes. So we did different types of assessment in that respect for SARA, and they did point in the same direction. that indeed we could not see that there was an evidence of any subtype requiring a separate item response model. I'll show another example from Parkinson's disease later when we did find that. But in order to give you the information in this diagnostic plot, I need to actually go through it a little bit because it's a little bit complex. So here we have the different subdiagnoses of interests, and here are the number of patients in the database. So you can see we go here all the way down to just 3 patients in the database. RSACs and FA are the 2 main subtypes, genetically defined. We also have those that are undetermined, or we have grouped all the one subject diagnosis together. What we did was we fitted the IRT model using all the data in the database. What we're interested in here is the individual contribution to the objective function value, and the objective function value is -2 times the log likelihood, and that's the overall goodness of fit criteria, and that's the sum across all individuals. In order to not have unbalanced data, we just randomly selected data from 1 visit per subject, and of course all individuals had scores on all these different SARA items. So what we did then was we looked at what is the mean individual objective function value. So in a sense, the mean goodness of fit for each subpopulation, and what's the mean individual goodness of fit for the entire ARCA population. And then we took the difference between those together with confidence intervals for those. And we then had that as the x-axis of this plot. So this is a forest plot where the a lack of deviation, an overlap with the 0 means that we have no evidence that the fit is worse or better than expected for any subpopulation. And as you can see, they're all overlapping the confidence interval with this. Naturally, it should be said that if you only have 3 or 4 or 5 individuals in a particular subtype, the power to determine that they have a different pattern to their symptoms or to their disabilities, then that would be low. What we have up here is we constructed a subpopulation or a population as a positive control, and this group here is a group which has its symptoms sampled from the empirical database of symptoms, but without any correlation between the symptoms. So this is a hypothetical subpopulation where they would have different combinations often compared to those of the ARCA patients. And we can see also that they actually deviate here from the 0 line. So the conclusions so far is that the SARA appears to be a unidimensional. That is, that there is a single latent variable that captures the data or causes the data. The results are in line with that. It's well performing with high discrimination values. All items are informative with varying importance at different disease severity levels, and that an IRT model seems to be applicable across the genotypes, or at least we don't have any evidence of the opposite. And for some of the more prevalent genetic subtypes, we could do additional explorations that supported this statement. But of course, we're not just interested in a snapshot in time, we're also interested in the disease progression. And here we can see the disease progression of the 10 most common subtypes in the ARCA registry. And as you can see, some of them have quite a few subjects data, whereas others are much more sparse. And what we did was that the fact that we use the same IRT model for all subtypes doesn't preclude us from having different rates of disease progression or different symptomatic picture at onset of the disease. So this is another diagnostic plot of how well can we capture the total score of SARA across time since onset of disease. So this is in years of the patient since the onset of the disease. And as you can see, it increases over time towards 40 here. And we can also investigate the goodness of fit at the individual item level. And then we look at the proportion of the total data that each observation in circles contribute with. And here you can see the different levels of item 1, which had actually 15 different levels. And you can see how over time, the low scores are diminishing and the high scores are increasing, in particular the highest one. So estimating the disease severity at onset on the x-axis and the disease progression rate, you can see that there was a distribution of progression rates and some subtypes have few individuals, and then of course the uncertainty in that progression rate is going to be quite wide, but others had more data and a more precise estimate of the progression rate. And we can then create, we can make clinical trial simulations for the different subtypes. And our interest here was to evaluate what is the sample size necessary for identifying a disease-modifying effect. So slowing down or stopping the disease progression. And in this case, comparing different ways of analyzing the data. So we can apply different models. We can use the item level data in an IRT model, or we can use the total score in a total score model. We simulate data from the IRT model because that's the only way we can compare these. And then we estimate the full model, which includes the model for the disease modification, and we fit a reduced model which doesn't. And then we can use the likelihood ratio test in the hypothesis test in order to see to what extent the treatment effect is discernible. And the middle point here is an IRT-informed total score model. Just to detail that a bit, there is a true relationship between the expected value of a total score and the latent variable value. And we can approximate that true relationship with a polynomial to an arbitrary degree of preciseness. And as you can see here, these are overlapping, so it's a very precise approximation. Same thing for the standard deviation. The expectation is that the standard deviation is typically low at the edges of the scale, and that allows us now to actually model disease progression at the latent variable level, even if we only have total score data. But let's here focus first on the total score analysis. And this is a study where treatment is compared to control in a 1-to-1 ratio, and we can hypothesize applying or that the included patient population is early after the onset of the disease, intermediate or late, or more heterogeneous. And what we can see here is that this is a 50% inhibition. It requires 200 subjects to identify with 80% power a treatment effect that is inhibiting the disease with 50%. And this is for RSACs, the most common of the subtypes in the ARCA registry. If we apply an IRT model instead, it's a smaller, the sample size needed is smaller, and that's because of what I said about using the data better, because we're actually now taking into account varying informativeness across the different items. What we can see is that actually the difference between the two ways of analyzing depends on which patient population you're choosing. We can also compare to these two if we use only the end of treatment data, so looking at change from baseline, versus the full longitudinal data, which is with visits every 6 months, is 11 data points as opposed to use only 2 data points. And clearly we expect that to be more powerful at the expense of additional assumption regarding the nature of the change. And that's what we're seeing. So instead of 134 subjects, if we use the entire time trajectory, we would need to use 258 for an end of treatment analysis. And the figures are similar if we're looking at the 100% inhibition. Naturally, if we can stop disease progression completely, the numbers needed are much lower. This was the same data as I just presented for, in this case, for 100% inhibition of in RSACs. If we move to from a 5-year study to a 2-year study, we can see quite a large difference in terms of numbers needed in the study. We can also see that with a shorter study, the value of longitudinal analysis is going down. So here it's a factor 2 between using all the data and using only the end of treatment data, whereas here it's only more like a 20% difference, even less. So the numbers needed is dependent on the progression rate. The higher the progression rate, the fewer individuals we need in a disease-modifying for a disease-modifying treatment trial. So the one subtype of those 10 most common was POLG, and if we look at the data there are less than half the size needed compared to RSACs, which has lower disease progression rate, but not actually as low as 50% of POLG. It's more like 60-70% of the POLG. So that about SARA, and I will be much briefer about the other project, Improve PSP, where we study progressive supranuclear palsy, which is a neurodegenerative disease with an unknown cause. The symptoms include problems with walking, balance, eye movements, cognitive impairment, speech impairment, and difficulty in swallowing. And the database here was a mixed database of 4 interventional trials and 2 observational natural history trials. In total, the database was also about 1,000 patients, with somewhat more data per patient than previously. The study duration was 1 year for the trials and longer for the observational natural history trials. But the patient population was very similar in age and maybe slightly more different when it comes to disease duration. So in progressive supranuclear palsy, there is a rating scale, PSPRS. That's the main rating scale. Again, this has been questioned, and the FDA was proposing an alternative set of items, or actually, out of the 28 items, they suggested 10 items as a better scale than all these items. And those selected items are illustrated with a star here. And it's already from these item characteristic curves, it's quite evident why some of these items might not be favorable in terms of characterizing the disease. These items like irritability and sleep difficulty showed no correlation with the other items, with the underlying hypothetical disability of PSP. So clearly, they are contributing more noise than anything else. And even if not knowing particularly much about PSP, it seems like irritability and sleep difficulty are much more general symptoms than what you would expect to be good symptoms for a particular disease. So it's maybe not so surprising that these are. So these 10 were the FDA selected items. And if we look at the information content, as I presented previously for the SARA items, and the discrimination parameters, we can see all the items, all the 28 are now ranked by their information content. And the FDA items are selected among the 10 items are selected among the 11 top items. And also for the discrimination parameters, you can see that they are also high compared to all the others. And we do expect a large correlation between information content and discrimination parameters when we have a similar number of categories for the different items. We can do sample size calculations also for trials here. A parallel group study, very similar in simulation setup. But in this case, a 1-year study, PSP has a more rapid progression rate. So a 1-year study might be sufficient. And here we look at a 50% progression inhibition. And the progression rate was for the PSP as a whole based on those interventional studies, assuming that a new study would maybe choose a similar recruitment strategy. And what we can see here is that if we look at the IRT model, you need a similar number of individuals, regardless of where you which item level, which items you include in the scale. And I should say, FDA also suggested the rescoring where some categories were merged, and that merger should only diminish the information content. It might have other advantages, but when it comes to the information content, we expect it to be diminished. The IRT informed model had required somewhat more individuals than at the individual level, but fewer than if we analyzed it on the total score model as a linear mixed effects model. So again, we see this ranking here. And that's one of the values of the IRT models. We typically have many choices. We have a selection of a patient population and what is both subtype and maybe age since onset or disease duration or age or whatever other covariate might be of importance. The chosen design, a treatment placebo 1-to-1 is maybe not an attractive design. There might be delay designs. There might be larger components of treatment, maybe different doses. And we might have different assumptions about the treatment effect that we want to try. Then we can, if we have an item response model, we can generate data at any level, item level. We can generate total score data. We can stage our disease in different stages based on one or multiple of the items, like loss of ambulations, for example. We can have responder criteria, or we can look at single items. And for each one of these different types, we might have different models. So total score can be analyzed as continuous type data, or it can be analyzed as discrete data. The most common way is as a continuous type, and that again introduces an assumption that might disadvantage a total score analysis. If we have disease stage models, maybe we want to do a time to event analysis or a multi-state model, etc. And with a IRT model, we can compare all these different options. I should also say that all the analyses I presented here about sample size, etc., assume that we did not borrow any information about natural history, progression rate from the data, but estimated that anew from each study. So, of course, with informative priors in the analysis, that's another way of decreasing the sample size necessary. So, just a few other comments finally on using the IRT model. I already talked about the ADAS-Cog being the IRT model being developed by two American databases. That's the Critical Path Initiative database and the ADNI database. So here an IRT model was developed that was later used in longitudinal trials of different companies. So we can utilize data from public databases or in-house clinical trial databases to develop the model, and then we can make use of that in hypothesizing what would be the case in a new trial. So in a sense, we separate the assessment component here. That's a separate model for the population component. And we can mix and match. So we can ask ourselves, for example, what would be a shortened version of ADAS-Cog performance in a mild Alzheimer's disease patient population, or in a minimal cognitive impairment patient population. And we can compare that with another version of the ADAS-Cog. And this is actually not uncommon questions. And in both our rare disease projects, it's questions about the setup of the clinical assessment. What is the instrument that's going to be used? And in ADAS-Cog, the original assessment took a long time, 45 minutes or so. For frail patients, that's a long time. And it's a burden for the clinical staff as well. So other shorter versions have been developed, as well as versions that are more targeting mild disease. And we can create a framework for doing this development using an IRT model. And this can lead to reduced tests options, so screening tests, trial conduct with limited tests, or with individualized dynamic testing. It's no use of having very difficult tasks for a severe Alzheimer's disease patient, just as there is no use of having those very easy questions for a very mild disease patients. And this can be dynamically organized. And we can see often there are just a subset of the items that can contribute a large component of the information in the total score. So in Parkinson's disease, typically there are not just one latent variable, because there are different aspects of the disease that are maybe developing progressively at different pace, and there are sometimes a need to make use of separate latent variables for different aspects of the disease. But again, just like I mentioned before, there is an interest that has moved to more early disease. And of course, if you start changing the instrument, then you might lose a lot of history of disease progression in patients. So there is a value of bridging between different instruments, and item response models are good at doing that. And I'll move on a little bit quicker here. So one of the things I said we were doing in pharmacometrics is trying to link different outcomes, so pharmacokinetics to pharmacodynamics. And we can do that also with item response models. So here we have in multiple sclerosis, we developed a model for EDSS. And in a second generation model, what we could do was to link important biomarkers like the absolute lymphocyte count, which was the mechanism of action of the drug, to the EDSS, to the latent variable, and similar for an imaging burden of disease biomarker. I talked about whether there was a need for separate IRT models for separate subtypes. I'm sure that many of you are familiar with the PPMI database, the Parkinson Progression Markers Initiative database, which are following patients with Parkinson's disease over time, and it's also capturing much information. In that database, patients were enrolled as Parkinson's patients, but with time it became clear that some patients that were diagnosed initially as Parkinson's patients actually didn't have any dopaminergic deficit, and they're called then SWEDs. And even later studies have shown that most of them never developed Parkinson's disease. So these could be considered as a misdiagnosis. And it's not so strange, because if one looks at the MDS-UPDRS distribution in those patients, it was very similar to those who actually were de novo Parkinson patients, and very different, well, quite more different from the healthy volunteers. So what we asked ourselves is, well, this is on the total score level, but if we analyzed it on the individual item level, would we be able to distinguish between them? And what we did was we took the data post screening and developed models separate for the SWEDs and the de novo. And based on those models, we asked, would those models be able to discriminate between the SWEDs and the de novo based on the screening data only? And when we did so, we could actually get quite a good separation. So where the total score was not of use in subdiagnosis the individual item levels were. So I just, before finishing, I just want to highlight that just because you have a clinical outcome assessment doesn't mean that an IRT model is a good choice or the best choice. It does rely on this disability actually being the driver of the different outcomes that you see. If you have, for example, patients under treatment of different drugs, and you have side effects of the drugs as part of the clinical outcome assessment, that's not a good idea, because clearly then that's not the disease that causes those. It's a different cause than the
You're muted.
Mats, we lost you, Mats. I don't know if I'm the only person.
No, Matt's muted himself.
I muted myself. Okay. I don't know how I managed to do that. Sorry.
No, it's just at the beginning of this slide, Mats.
Of this slide or of that slide?
No, this one was okay, at least for me, and it's the next one. I don't know for the others.
So the next one I actually didn't get to.
No. I'm sorry, this one I was saying.
Okay, this one. Yeah, fine. So yeah, what I was saying was that the IRT model sits best with the reflective indicator model, as FDA calls it, where you have an underlying concept that causes the outcome of the assessments. So that doesn't mean that all clinical outcome assessments would be that IRT models would be the best or even a good solution for all clinical outcome assessments. And if you have side effects, for example, they typically they of course have a different cause than the disease. So if your outcome assessment includes side effects, that's probably not a good idea to have an IRT model. Another situation is where you have a concept that is created based on weighted or unweighted items. And one example there is the SLEDAI score in lupus, where you can see that there are several items here that are being present or absent, and they're scored with very different values. And this is to illustrate their clinical importance. So an IRT model would not recognize that this is more important than this. It operates just trying to capture that underlying joint disability. So there are situations where an IRT model could be a useful alternative or a useful way of analyzing composite or clinical outcome assessments, but those where it's not. So my final two slides. This is a potential use of IRT modeling in clinical drug development. This is focusing on the aspect of more traditional development in more common diseases. And of course, how we're going to use IRT models in rare diseases is something we're working on now within the EJP RD, at least in our projects. So, but here, before you go into patients, if you have an IRT model, you can leverage more existing data. You can select more specific patient population for what might be a good idea, depending on symptomatic or disease-modifying treatment. And you can choose endpoints. In the early phase 2 situation, if you're doing internal decision making, you might infer with higher power with an IRT model, or understand the profile of your drug with more detail. And planning for phase 3, you can design more precisely for a regulatory accepted endpoint, or decide on things like dose selection with increased confidence. For the phase 3, you can use IRT models in inclusion criteria as inclusion criteria components. You can use them as dynamic selection of tasks during the trial, and you can combine, for example, continuous variables, all the tasks at clinical visits, and maybe selected ones in between. And this could go into interim analysis, maybe futility analysis, or adaptive designs. And even if the final analysis is not going to be IRT model based, it can contribute to a more informed exposure response analysis or benefit risk ratio. It can help defining disease modifying effects versus symptomatic effects, as well as biomarker validation as for further development. So with this, I'm going to stop and I want to acknowledge the 2 consortia in which I work with these aspects. The evidence R&D for the ARCAS, the ataxias, coordinated by Matis Synovsik, and the Improved PSP Consortium coordinated by Günther Höglinger. And I've highlighted here in blue the PhD students in the different projects that contributed data to this presentation. And of course, I want to also acknowledge the EJP RD, which are these projects. So with that, thank you very much for your attention, and